Good morning, dear students. Let's start our lecture and topic today: allergic lesions of oral mucosa in children. Allergies. Allergy is an immune reaction of the body to exogenous substances of antigenic or heptenic nature, which is accompanied by damage to the structure and functions of cells, tissues, and organs. Allergens, it is substances that are capable of causing the formation of antibodies and an immune response of the humoral and cellular type. And you should know about different types of allergens. First type, it is exogenous, for example, infectious and non-infectious. Two infectious type include viruses, bacteria, and fungi. And for non-infections, it is food and different medication, epidermal. Next group, second group, it is endogenous factors and congenital, for example, normal lens tissues or nervous tissue, and acquired. Pathological tissue, they are formed when damaged by microorganisms, viruses, exposure to high and low temperatures. So, some classification by ways of their entry into the body. So you should write this classification. For example, pneumoallergens, elementary, contact, parenteral, and transplacental. The first hit of an allergen in the body causes its sensitization, and repeated can cause allergic reaction. And classification of allergic reaction by Combs and Gel. First reaction, it is intermediate reaction, and this reaction includes three types of reaction. First type, it is reagenic or atopic and anaphylactic reactions. So clinical manifestations, it is anaphylaxis and quinquedema, atopic dermatitis, asthma, rhinitis, and etc. The second type, it is cytotoxic. So clinical manifestation, drug allergy, anemia. Three type, it is immunocomplex with immunoglobulins, different of classes. In this type, it is class M and G. And clinical manifestation, so different reactions, sickness, and delayed response. For type, this food type occurs due to the interaction of the allergen with a type of lymphocytes. So different reaction from exudation to proliferation, and hyperplasia of the lips, cheeks, and gums. And clinical manifestation in this group, it is allergic contact dermatitis, stomatitis, and graft rejection reaction. Pathogenesis of allergic reaction. Immunological stage, it is, or you can call the period of sensitization. This period lasts from the moment of the initial contact of the immune system with the allergen until the development of sensitization of the body. And next reaction, it is pathochemical stage. This stage develops upon repeated contact of the immune system with a specific allergen, and is characterized by the release of allergy mediators. And next reaction, Pathophysiological stage, this reaction of organs and systems to different mediators of allergy and immune complexes. And adaptive stress response. Primary mediators of allergies, first of all, it is histamine. This mediator increases vascular permeability and causes smooth muscle reaction. Serotonin increases vascular permeability and also causes smooth muscle reaction. Chemotasis factor of eosinophils, FCT factor, stimulated eosinophil chemotaxis, and neutrophil chemotaxis factor, so stimulated neutrophil chemotaxis. Proteases, they cause secretion of mucosa and doing degradation of the basement membrane of blood vessels. And secondary mediators, it is platelet activation factor. It causes aggregation and degranulation of platelets and contraction of the smooth muscles of the lungs. Leukotrienes increase vascular permeability. Prostaglandins, they cause contraction of the smooth muscle also. And bradykinins increase vascular permeability and cause contraction of smooth muscles. So, allergic reaction of intermediate type. I think you know about Quink's edema. Yes, it is very necessary information because all of you unfortunately can see this Quink edema or hear about it from your colleagues. So, angioedema or Quink's edema, it is local allergic reaction of type 1. It is very quick type, a very quick reaction. And this reaction occurs at the site of contact with the allergen and is manifested by the rapid development of localized edema due to the release of inflammatory mediators from tissue basophils. So you can see clinical photos when you can see Quink's edema and manifestation of the upper lips. And first picture, manifestation on the lower lips. So it is very quick reaction. Symptoms. First, tingling, pain in the corresponding area. So then swelling of the facial tissue of the skin from 2 to 10 centimeters and stands out clearly pale. Swelling of the feet and backs of the hands. Swelling is dense when pressed with a finger, does not form of characteristic fossa. And localization, it is lips, eyelids, cheeks, pharynx, larynx, and can be combined with urticaria. So, swelling of the pharynx, larynx, or trachea. It is difficulty breathing, anxiety, yes, and the emergence of a barking cough. So, emergency care for Quink's edema. First of all, you can stop administration of the allergen of the drug. For example, when doctor doing anesthesia, yes, so anesthetics, it is allergen. So, prescription of antihistamines. You should inject 1 millimeters or 1% solution of diphenhydramine, or 2 millimeters of 2% solution cyprostine, or 2 millimeters 2.5% of solution of pipelfen. Per OS, you should prescribe one of the following antihistamines. Diphenhydramine for children from 1 to 5 years, and you can see grams of syrup, and for 6 and 7 years, and you should doing it every 4 hours. Diazolines, 2 times a day. Cyprostine, also from 1 to 6 years, it is 1-3 tab, 2 times or 3 times a day, and children from 6 to 14 years, 1.5 tablet, 2 or 3 times a day. So loratadine or claritine from 2 to 12 years, and here you should understand weight of patient up to 30 kilograms. It is 1 time per day, and over 12 years. With asphyxiation, so solution of adrenaline hydrochloride, and with prednisolone solution. When patient have laryngeal edema, you should doing intubation of or tracheotomy. And of course, we should call emergency help in all situations. Ways to stop the intake of an allergen in the body. So, in the event of a reaction to a drug administered parenterally or with an insect bite, application of tourniquet above the injection site for 25 minutes. To the injection site, ice or a heating pad with cold water for 50 minutes, and chipping at 5-6 points and infiltration of the injection site or bite, so with adrenaline solution. Anaphylactic shock or anaphylaxis. It is general allergic reaction of the immediate type of to repeated administration of an allergen. So you should know about some forms. It is typical, hemodynamic, asphyxial, and cerebral and abdominal. This table, it is termination, received allergen and anti-shock activity, and anti-allergic therapy. So it first applying a tourniquet, chipping adrenal rush of the place injection or bite. The second is adrenaline and transfusion of liquids, and glucocorticoids when it is anti-allergic therapy. Emergency care for anaphylactic shock. We should to stop administration of the allergen, lay the patient horizontally in the chair, and turn the head to one side, fix the tongue, or provide airflow. So fix the tongue, it is not sure, it is not for all situation. Yes, it is for 2 or 3% situation, not for all. We should enter per os or in muscles solution of adrenaline, or solutions or adrenaline with physiological solution. To stop off the injection site of the allergen, and solution of adrenaline or physical solution for 5 millimeters, and cover with ice. Introduce prednisolone, so from 3 to 5 milligrams to kilogram body weight. or dexamethasone. Introduce 1% of diphenhydramine solution intravenously, or 2% 2 millimeters of supprastin or pipelfen. With bronchospasms, 2 and 4% of 10 millimeters of aminophylline. So adrenaline is very necessarily medication, and it is first step in emergency help. As an activator A and B adrenergic receptors, is the main drug in the treatment of anaphylaxis shock. So adrenaline, 0.5% for children, and intramuscularly or subcutaneously, and a maximum dose of 0.2 to 0.5 millimeters. Remember, please. If it is necessary to repeat, doctor should repeat after 5-15 minutes, up to 2 doses. Adults and child over 12 years, child 6-12 years, and child over 6 years, all to look, please, different milligrams. So adrenaline is administered only by experienced specialists, so adults and children. And corticosteroids, hydrocortisone, introduced intravenously and based on 5 millimeters to kilogram weight. If necessarily, can be repeated every 6 hours. And this picture of medication of adrenaline in our pharmacies. Criteria for instrumental and laboratory routine for anaphylaxis. So it is from protocol order number 24 in January 2005. Okay, so we should know about heart rate. Sorry for this picture. Here I see mistakes. So heart rate, then frequency and breath, then auscultation of leg and heart, then extensions, clinic blood analysis for hemoglobin and hematocrit values, then general urine analysis, biochemical blood parameters, so calcium, sodium, blood gas, calcium, blood cells, glucose, bilirubin, urea, and alpha amylase blood, and electrocardiogram. So differential diagnosis of anaphylaxis with other pathological conditions. So first it is clinical signs, and then different so shock, edema, Quincke's edema, fainting, and collapse. So swelling of the soft tissues of the face and lips. So plus only when patient have Quincke's edema. Decrease in blood pressure, so plus on anaphylaxis shock, fainting, and collapse. Weakness of feeling the pulse, so plus it is anaphylaxis shock, fainting, and collapse. Asphyxia plus anaphylaxis shock and Quincke's edema, and loss of consciousness, it is plus anaphylaxis shock, fainting, and that's all. Forms of drugs, allergic injuries of delayed type oral mucosa. So clinical and morphological characteristics, it is catarrhal, papular, erosive, and ulcerative. So by localization of pathological lesions, it is stomatitis, cheilitis, and glossitis. So, allergic reaction of delayed type of OOPR, so contact stomatitis, caused by dentures, dressings, and application and aerosols. Toxic allergic drugs, lesions, and fix. It is sulforetama, tetracycline blisters, and common is catarrh hemorrhagic, and gallbladder, erosive, ulcerative necrotizing stomatitis, and different syndromes. Contact toxic allergic stomatitis. Complaints, so burning, itching, dry mouth, pain while eating, hyperemia and edema of the oral mucosa. The tongue is hyperemic, the papilla of the tongue are hypertrophied, if for example raspberry tongue, or atrophied, for example liquorate tongue. And allergic reaction on chloramphenicol. It is vesicular bullous stomatitis, and it is toxic allergic nature. Look please on the case. Basic principles of treatment of drug-induced allergic lesions of delayed type oral mucosa. Cancellation of the drug, it is allergen. General and local use of etiologic, pathogenic, and symptomatic drugs take into account the severity of the disease's age, general conditions, and reactivity of the body. To reduce the effect of biologically active substances, antihistamines are prescribed per OS. And examples of antihistamines. So the course of treatment is 10 days, minimum 10 days. Anti-inflammatory drugs and vitamin diet, spicy food, and alcoholic beverages are prohibited. So, treatment of drug-induced allergic lesions of delayed type oral mucosa, drug groups, local anesthetics. It is 1 and 2% solution of lidocaine, chemostat gel, anesthetine in perch or olive oil, and 0.511% solution of novocaine, etc. So, purpose of application, elimination of the pain. Next one, it is hypersensitizing drugs. 0.1 solution of diphenhydramine, etc. It decrease in toxicity of BAS. And antiseptics, 1% solution of hydrogen peroxide, and it reducing exposure or killing microorganisms. Treatment, then non-steroidal anti-inflammatory drugs, and examples: non-steroidal anti-inflammatory drugs, hydrocortisone, prednisolone. These drugs elimination of inflammation and reduction of exudation. And next one, enzyme preparations: trypsin, chymotrypsin, lysosine, chymopsin. The removal of fibrous or necrotic plaque. For example, necrotic and ulcerative stomatitis or gingivitis. Then immunomodulators. It is 1% solution of sodium nucleonate and 5% methyl ointment, lysosine, herbisol, etc. The stimulation of local immunity. Keratoplastic drugs, it is vitamins groups A, E, and oil, keratin and vanillin. They stimulated of epithelialization of the oral cavity. Then allergic purpura or hemorrhagic vasculitis disease. So the vessels of any area are affected, including lungs, including brain and its membranes, papilla, hemorrhagic rash, sometimes with blisters, articular syndromes, and abdominal syndrome. So it is abdominal pain. Then hemorrhagic rash of the gums, cheeks, tongue, and palate. Petechia and hemorrhagic spots with a diameter of 3 to 5 millimeters to 1 centimeters do not protrude above the CO level and do not disappear when pressed with glass. And chronic recurrent ephthostomatitis, please look. It is white spot, ulcerative spot, and hyperemia. Treatment scheme for this type of stomatitis. So remediation of chronic infection, elimination or predisposition factors and treatment. Then sanitation of the oral cavity, pain, relief of the oral mucosa. So topic anesthetics, 5% anesthetic emulsion. Then application of proteolytic enzymes to remove necrotic plaque. Treatment with antiseptics and anti-inflammatories medication, application of keratoplastics agents, then desensitizing therapy, vitamin therapy, immunomodulatory therapy, and means that normalize the intestinal microflora, and physiotherapy treatment, for example, haloneon laser radiation. Then exudative erythema multiforme, it is allergic reaction type 3. Pathogenesis, so blood formation and intercellular fluid, is circulated immune complexes, which include antibodies of the class of immunoglobulins G and M, and antigens type 3 allergic reaction. Next one, tissue damage by initiated immune complexes through the activation of complement and leukocytes. Exudative erythema multiforme, the form of infectious allergic, true or idiopathic. Then etiological factor, infections, allergens, and different microorganisms. Source sensitization, dysphagia, or chronic infection. Then toxic allergic, symptomatic, non-infectious drug allergens, and medications, for example, antibiotics and salicylates. Then clinical signs, erythema multiforme. Look please in these pictures. Against the background of hyperemic and edematous mucous membrane, multiply spots and erosions and ulcerative mucous membranes, yes, and absence of Nikolsky symptom. Clinical signs on the skin of the back of the hands, macula, papilla, symmetric rash of cyanotic purple color with a bubble in the center. It is Cocards. Clinical signs, erythema. Rash polymorphism, the red border of the lips and the skin, and the face is covered with blood crusts and purulent films and erosions. Also exudative erythema. And differential diagnosis. Features of clinical manifestations. Then lymphatic Q nodes, Nikolsky symptom, cytological cues research, and serological reaction, and allergy tests. You should write this table in your synopsis. Syndrome of Stevens-Johnson. So, erosive pleuropharyngeal ectodermosis of Fissens rando, and then bad dermatostomatitis, and pemphigoid erythema multiforme. Sharp start. General conditions worsens progressively. Skin lesions, it is pain, burning sensitization, it is paresthesia, increased sensitivity. So, erythematous papilla or vesicular bullous rash, and diffuse stomatitis. Also, treatment is carried out in a hospital setting. Syndrome of Lyell's. It is toxic epidermal necrolysis. So, identify and cancel the drug that causes toxidermia. Infusion therapy, corticosteroids. In case of damage to the oropharynx, completely necrotic skin is removed. Identify the treat infectious complications, including sepsis. So, very difficult syndrome. And it is a differential diagnosis from our book. So the previous slide, I wrote the table for you. Thetans stomatitis. Look on the case. So the clinical course is an undulation and long course leading to the significant deformation of the oral mucosa. The number of elements is from 2 to 10 millimeters and rarely more. A creeping ulcers is characterized by healing at one pole with growth at the order, and size from 1 centimeter up to the defeat of significant areas of oral mucosa. Localization of aft is oral mucosa covered with stratified squamous non-keratizing epithelium. However, with growth, the ulcer can also spread to areas with keratinizing and of epithelium. And the course is up of 1.5 months. Healing occurs with the formation of a deforming scar. Look, please. Bechet syndrome. Manifested by defeat, so it is aft, it is ulcerative lesions, it is all lesions that localize on the eyes. Please look. Allergy history, features of the clinical course, then clinical laboratory research, conducting specific allergological and skin allergic tests, hemogram, and immunological studies. Reaction type 1 and mechanism, it is immunoglobulins of class E. So it is a determination of this immunoglobulin in blood serum, dermal and sublingual, and other tests. Two types, cytotoxic immunoglobulins G and M, and specific antibodies in serum. The type 3 immunoglobulins G, M, and IR, it is determination and identification of oral cavity, skin, etc., and different tests. Type 4 T lymphocytes, identification of immune T type of lymphocyte. What are the specific types of allergy tests? So scarification or prick tests, then intradermal tests, blood test or rest test. Provocative tests, these tests are performed only when all of the above tests impossible, but at the same time the patient needs a product or drug to which he may be allergic. So nasal, conjunctival and sublingual, and inhalation. Cutaneous diagnostic tests, these prick tests. So we should take different allergens, and then we should know the size of reaction of the skin. So here it is negative control to histamine. So here I use loratadine, and look please the size, first size, second, the third. Thanks for your attention, guys.